Hello, I'm Matthew Gavidia. Today in the MGH Life Sciences Medical World News, the American Journal of Managed Care is pleased to welcome Meena Venkatachalam, Senior Director of Health Economics at PRECISIONheor, and Jason Shafrin, Vice President of Health Economics at PRECISIONheor. Can you both just introduce yourself and tell us a little bit about your work?
Hi, this is Meena Venkatachalam. As I mentioned, Senior Director of HOR. My background is in health economics. I'm actually based in our London office, and I work a lot on development of cost effectiveness models for the purpose of HTA submissions.
Great, and I'm Jason Shafrin. I'm a Vice President at PRECISIONheor. My background is also a health economist. I'm also the founder and editor of the Healthcare Economist blog.
Amid the pandemic, disproportionate access to care and severe COVID-19 outcomes have been spotlighted in minority communities, especially among Blacks and Hispanics. Can you both speak on some factors that contribute to these disparities?
Sure. I think there's obviously a number of factors that are contributing to that, but I think few of the obvious ones that I think people are mostly aware of is one is access to healthcare. Obviously, there's differences in insurance coverage. We pointed that out in our piece. Some statistics show that there's actually about 13 years difference in health insurance coverage between African American population and other minority groups. So obviously, when you've got that financial pressure of accessing care, that can lead to differences in outcomes as well. But beyond just the financial pressure and coverage of insurance, I think there's also barriers to access. So if you think about factors like ease of transportation, childcare, having a job that's flexible enough for you to go see a physician, all of those are also factors that are barriers to access. And I think another factor, which is that even if those two weren't at play and it wasn't about health insurance coverage and it wasn't about access, there's also increased risk of exposure. There are some statistics that show that minority groups are more likely to be in essential working jobs. So that puts them at a higher risk. Also culturally, you could be in homes with larger families, communal living, smaller housing, all of that increases your risk of exposure. So I think all of these factors at play, it's hard to pinpoint which one it is specifically, whether they're cumulative, additive, but there are a lot of things at play that are specifically affecting the minority population versus other ethnic groups.
I think one thing just to add on, certainly just kind of waiting times and access, even if you do have insurance. Meena mentioned the social determinants of health, but I think there's been some studies that show that Medicaid patients were, the wait times just to get into the doctor's office were 20% longer. So, certainly, the care access once insurance is important.
How can the current healthcare system better address health-related issues prominent in minority populations, especially when it comes to clinical trial participation on novel therapies?
So I think really for this one, it's the clinical trial participation is pretty important along two dimensions. So the first is when you're going to be investigating a disease, and you want to make sure that the trial is representative, in terms of, ethnically, racially, culturally, socioeconomic status, of that disease. And I think that's a bit more straightforward. The second dimension, though, is, you want to ensure that the drugs in the pipeline are representative of the diseases that are affecting the whole population. The FDA actually has an annual snapshot where they compare enrollment in clinical trials in the previous year against the racial and ethnic composition of the country as a whole, age groups, its gender, et cetera. So that's kind of a helpful first step to just kind of keep track of what we're doing. But also it's important to incentivize getting people to develop those treatments. And that's where having value assessment frameworks that incorporate inequality into those are important for getting those incentives.
Yeah, I think I echo the same comments. I think research and development right now reflects the incentives that are there for the pharmaceutical industry. And if value frameworks stay quite closed, the incentives are smaller to invest in therapeutic areas that impact minorities. So I think a lot of what we're writing about and talking about now is how to sort of expand that so you do incentivize it. Because I think unless there is that, it's hard to get research and development to really match the needs.
Beyond research and developmental issues, there is a notable gap in traditional value frameworks that would consider treatment's impact on improving equity and health outcomes in disadvantaged communities when it comes to incentivizing reimbursement. Can you speak first, Meena, on what an ideal framework would entail and how it can be incorporated into the current U.S. healthcare delivery system?
Yeah, I mean, I think so. Our paper is sort of speaking about what the ideal framework could be. Right now, it's not measured. You know, if you really look at ICER or even beyond the US, it's not really considered at all equity concerns. So I think a first baby step in this process is actually getting value frameworks that actually consider equity. So two of the approaches that we've mentioned is multi-criteria decision analysis and distributional cost-effective analysis, which actually formally include impact on equity as a criteria in the model. So it expands the traditional framework. So I think unless you can measure something, you can't make decisions on it. And right now we're not measuring it at all. So I think an ideal framework is at least making that first step to measure this impact and the value of a drug on these issues.
And I think, really getting at the ideal, Meena mentioned some of the methods with the distributional cost effectiveness and the multi-criterion decision analysis. And I think some of those kind of ideal are with the distributional cost effectiveness, you kind of have one number that can be helpful for people that incorporates inequality. For the MCDA approach, for people who are a bit more active and they want to see, well, I want to prioritize overall health gains or side effects or costs or inequality, you can do that a bit more in an evolved way. So I think there's not one kind of ideal way to do that, but I think Meena's right that getting the tools there and at least starting to incorporate the value of reduced inequality is extremely important.
And Jason, you could go first here. But what further steps are warranted to address inequalities in health outcomes among minority communities?
Yeah, I mean, I think that's a question for a 3-hour-long seminar symposium. Certainly a big issue. I think just really kind of narrowing it down to in terms of new treatment development, really getting the DCA, MCDA methods that are really well known in academia, and getting those implemented. And the reason is not just I'm a health economist by training. It's not just to do it for technical reasons and because it's fun, but it's really because we want to incentivize life sciences to create treatments that will improve health outcomes for disadvantaged communities. And really by doing that and saying, hey, if you have a treatment that improves health, that's great. But if you improve it for disadvantaged communities that are really having poor health outcomes, that's even better. That will really put the right incentives in place and allow people to make explicit trade-offs to incorporate those.
I think sometimes people might see this as it's too far of a jump, like this is just an academic piece and it's too far to think about actually applying this in a real world setting. But I don't think this is an uncommon trend. We've been in these situations before where academic groups respond to a gap and a need where we're lacking something. There's methods that are well published, well validated, they're just not being used. And I think our kind of piece right now is let's use them more. We don't need to reinvent the wheel, it exists. It's measuring the impact on equity. So if we use this, then we can get decision makers to be a little bit more accepting of it. And that trend is consistent. That kind of cycle of innovation is pretty common in our type of work.
And lastly, do either of you have any other concluding thoughts?
I think for me, I mean, I think it's the problem is certainly, high, it's multidimensional, and, life sciences, drug development is just one piece. And certainly a piece that's near and dear to my heart and the research that I do, but certainly a multifactorial issue that we need a lot of hands on deck to help improve health outcomes for the disadvantaged communities.
Yeah, I think we're somewhat limited what we can do with HOR research. We can't influence like investment in certain drugs directly, but I think our research can indirectly kind of nudge in the right direction. So if we increase incentives to invest in these areas through value frameworks, that's one way to nudge. And there's multiple ways to nudge. It may not address all of the issues, but it's one part of the puzzle that we can help address.
To learn more, visit our website, agmc.com. I'm Matthew Vidia. Thanks for joining us.